Hello, everybody. Thank you so much for joining us for our first 2022 Virtual CEU event of the year. If this is your first time joining us, welcome. And if this is a returning visit for you, welcome back. My name is Jordan Peterson. I am the Director of Business Development and Marketing for our Aurora Behavioral Health Hospitals here in Phoenix, Arizona, and Tempe and Glendale. Joining me today, I have quite a few people here. I'm going to introduce a couple of them really quick. First and foremost here on my team, the folks that might be able to be identified pretty quickly here is some of our team members, our community liaisons. We have Miss Valerie Purdy, Debbie Elder, and Kevin Brown. And then we have a few guests here because this is a partnership CEU event with some great friends of ours, the Scottsdale Youth and Community Coalition. So I do also want to introduce from there, Miss Christine Driscoll, and someone who's going to be our moderator for the day. I would like to introduce Miss Rachel Rubenstein. And just to give you a little bit of a bio of Rachel, and then she's going to take it away from here. Rachel Rubenstein is a board certified licensed clinical social worker in the state of Arizona with over 20 years experience in the mental health field. She thrives when sharing creativity, knowledge, perspective, and decision-making with her clients. She is the owner of the Counseling Consultants PLLC and serves as the executive director of the Scottsdale Youth and Community Coalition. She's been in private practice since 2008 and currently provides telehealth counseling services to communities across the state of Arizona, including children, adolescents, and adults. Now, one final reminder before I fully give this over to Rachel is we encourage you guys to ask questions, but this might not look like a traditional Zoom meeting. And that being said, there is the option to hit the raise hand feature, things like that. Unfortunately, those can cause a lot of technical glitches. So what we would like for you all to do is when you have questions and they come up to you, we don't want you to forget them waiting until the end of the presentation. So instead, you'll see at the bottom of the screen there, you have a chat option and you have a Q&A option. We recommend, if you do not want a question to be lost in the shuffle, please go ahead and hit that Q&A box and type your question right on into there. And we'll be happy to help address that, whether it be at the end of the presentation or if there's a natural transition point for that. So that being said, I am going to put us in the trusted hands of Miss Rachel Rubenstein.
Thank you so much. I wanted to thank Aurora Behavioral Health System on behalf of the Scottsdale Youth and Community Coalition. We love co-hosting with you, and we're super excited about our speaker this month. I wanted to just acknowledge other board members on the call: Christine Driscoll from Rosewood Centers for Eating Disorders, Sherry Eklund from I Am Teen Strong, and Jen Cohen from Resilient Health. A little bit about the Scottsdale Youth and Community Coalition, because we love our coalition so much. Basically, we're a group of professionals that are supporting youth and families through engaging, educating, and empowering. For example, with this Lunch and Learn, and we focus on mental health, substance use, and eating disorders. There should be our contact somewhere. If not, just Google us, Scottsdale Youth and Community Coalition. We are so excited to have Robyn Goldberg with us. If you haven't already, her book is so helpful. I've been a clinician for a long time, and I have learned so much from your book, Robyn. I'm super excited for how it's going to help me in my practice. So a little bit about Robyn. Robyn began her career at Cedars-Sinai Medical Center in Los Angeles as the inpatient dietitian in the Department of Cardiology. Over the last 25 years, she has developed her own private practice in Beverly Hills, California, where she specializes in medical conditions, disordered eating, eating disorders, health at every size, pre-pregnancy nutrition, and people in recovery. Robyn is a certified eating disorders registered dietitian and supervisor from the IAEDP. She serves as a nutrition consultant for the Celiac Disease Foundation. And for the last 8 years, Robyn was the nutrition counselor for the Susan Crevoy Eating Disorders Program at the Wright Institute of Los Angeles, and led eating disorder and body image groups at the various sober livings in Los Angeles. She is contributing author and is a nationally and internationally known registered dietitian nutritionist. She has been quoted in the New York Times, the Huffington Post, The Fix, Shape Magazine, Fitness, Oxygen, Pilates Style, Diabetes Forecast, BH Weekly, and Lifestyle. She has been on national television as the eating disorder expert on The Insider. Robyn is the author of the new book, which I highly recommend, The Eating Disorder Trap, A Guide for Clinicians and Loved Ones. and the host of the podcast, The Eating Disorder Trap. Super, super excited to pass it over to Robyn. Thank you for being here.
Thank you so much for having me. First of all, thank you so much to Christine Driscoll with Rosewood Center for Eating Disorders, Aurora Behavioral Health, and of course, Jordan, Rachel, and the rest of the team for inviting me. It's such an honor to be able to present to your audience. Very, very excited. So I'd love to be able to share my screen and jump into this. So have you freed it up, Jordan, or?
You should have all permissions,
Okay.
and just give it a whirl and see what happens here.
Okay.
Perfect.
Hold on. Sorry, let me. Voila. Okay. Cool. So let's see. So the title of my talk today is, Does My Client Have an Eating Disorder? And I think this is so relevant always, but I would say the last 2 years during COVID, the rise of mental health and eating disorders has really just exploded. So anyone that does what I do is swamped and maxed out, as well as even Rachel and I were discussing this, even in mental health. I think just all mental health care providers and eating disorder clinicians are just feeling they're always putting fires out. So hopefully everyone will gain some tools today. So I wanted to start out, and the way my discussion today will go is the role of the registered dietitian nutritionist. I think oftentimes individuals don't know where someone like me fits into the equation. Of course, the signs and symptoms that are not so obvious. I think it's important that we discuss the various meanings of quote unquote normal, because that's such an arbitrary term. And of course, when to refer out and where to refer out, and then all your questions we're going to save to the end. I know Rachel will be moderating that. So in the 25 years I've been in practice, I can tell you that body image and eating disorders has really changed, and it's something that a clinician really needs to stay up to date and current on, because there's always new research and techniques and diagnoses out there. So my role when I'm seeing a person is to evaluate if the individual is safe to be in an outpatient setting, and to be able to look at what level of care they actually need to support them with treatment for their eating disorder. Like the lowest is medical stabilization, like what they do offer at Rosewood. And that's where an individual's just being able to get their organs to a stable place so then they can transition to a residential eating disorder treatment center. And then, of course, there's PHP, partial hospitalization program, and IOP, an intensive outpatient program. So, during COVID, of course, I was not seeing people in person. And actually, yesterday was the first time in almost 5 weeks I saw 2 clients in person, because it's so different being virtual, where I'm not able to feel an individual's temperature of their hands, and their skin color is different on Zoom. And there's nothing like, of course, having that face-to-face interaction with our clients. So I find I have really become creative and clever over these last couple of years on Zoom in how I can assess where a person is at medically, because I was actually trained by one of the top adolescent medicine eating disorder physicians. So between that and then my own clinical experience from when I worked at Cedars-Sinai Medical Center, I really pride myself on being able to evaluate a person and see them week after week, because I know many dietitians don't have that training. Another part of my job is to be able to teach clients how to recognize their different levels of hunger and their different levels of fullness. And that can be oftentimes a disconnect for many, because if they've been a chronic dieter, if they engage in laxatives and diuretics, if they engage in other self-destructive behaviors such as bulimia nervosa, purging via finger, toothbrush, exercise, many other forms. And again, the other part is sometimes individuals have multiple eating disorders, or one can morph into another, and it really takes them away from being connected to their body. So I spend a lot of time teaching people how to really learn how to self-regulate and understand what that looks like. Also helping, the individual learn how to neutralize and legalize all foods and food groups. So what that means is, diet culture affects all of us. And every day, and I think to myself, if I wasn't in my profession, I would be confused and overwhelmed because we're told to eat a specific food, to not eat a specific food. We're told, you can only eat this amount or at this time or have these various combinations. And it can be a very overwhelming experience. And especially over COVID, if an individual had disordered eating or an eating disorder before, and perhaps it sat on the sideline, the last 2 years of the trauma of what everyone has gone through has really escalated because eating disorders thrive on isolation and to tell you that you have failed and you're not doing this correctly. So I spend a lot of time, and I actually talk about this in my book, The Eating Disorder Trap, about debunking myths regarding carbohydrates, proteins, and fats, and being able to look at there's no such thing as a quote unquote good food or bad food. All food has nutrients and value behind it, and really to work at where these messages originated from and how to change that narrative for someone. I always like to be able to share, clients' successes instead of the shame. And it's so common, and I know many providers see this that aren't even in my field, when an individual will want to cancel an appointment if they've had a rough week and there's nothing quote unquote positive to share. And I like to talk about what was challenging for you and how can we come up with a game plan to be able to escalate and move forward, as well as to celebrate all the little victories along the way, because that's what helps to establish consistency and confidence within a person being able to make long-term changes. Also, self-care, something I know we all do in the eating disorder mental health field, is really want to talk about self-care, and I'll mention the self-love piece in a moment, but self-care, it doesn't have to be, oh, I'm going to a spa. It could be, you know what, I'm going to bed a half an hour earlier, or you know what, instead of staying in my office all day, every hour, I'm just going to go outside and get some fresh air. So I really try to break it down on a basic and fundamental level, something that is tangible to incorporate into one's life. Self-love, that is a long-term goal to be able to, self-love, develop that for ourselves. So I'll actually start with being able to say, do I like myself? Or if a person doesn't like themselves, can I tolerate myself? So maybe starting with a place of tolerating myself to liking myself, and really trying to look at how to build. It's kind of like reconnecting to your body's hunger and fullness cues with just having that level of caring for ourselves. How to identify danger signs? I mean, there are so many, and this I had to really just cut off when I was creating my slides, okay, when I'm just going to end it, because that could be literally a presentation within itself. So oftentimes individuals will use, and it's become normalized in our society, using diet talk to start out each day. I am going to be good today. I'm not eating such and such. I can only eat such and such when I've walked 30 minutes, or because I ate such and such, I have to go on the treadmill. So that's diet talk. And many times people aren't even aware that's diet talk because that's been normalized in our society. When an individual avoids eating with certain people because they feel like they're being judged, or it could be a trigger. Well, I want to be able to have the tuna melt, but this person's always eating the salad with the chicken. They feel like they're going to be judged, or it's their own insecurity that's being reflected by the other person. They force themselves to exercise even when they're tired or injured. This I see time and time again. I was speaking with a client yesterday who I've been seeing for many months and is medically stable, and her eating disorder physician had allowed her to be on the basketball team now that she's quote unquote medically stable, just to have some social interaction with friends at school. And we've discussed when I was feeling her hands yesterday, I felt like she was in an ice cream shop, and when I was taking her pulse, it was very difficult to find. And we were talking about how she took the week off because the family was on vacation, and she's like, Robyn, I didn't do any exercise, and I was wanting to restrict more. I was like, traveling is movement. I'm like, going through airports is movement. I said, if you were sitting in a bed, this is not movement. Oh, because they were in Costa Rica. I said, do you view zip lining as not being exercise? She's like, it's not exercise. I was like, it's not sitting under an umbrella reading a book. So that's yes, it's a different kind of exercise. So I feel like part of the problem is people will view high intensity movement as exercise only, or if they are injured and they're working through pain, they still feel like they need to move. And that is a warning sign. Also, the judgment that individuals will experience with, regarding like, well, I could never eat such and such because if I eat this, I'm going to look like that person. And they will judge a person's appearance based on the food choice they make, which is false. There's people that naturally live in larger bodies, just like there's people that naturally live in smaller bodies. So what we're eating is not directly related to our external appearance. It's like I always say, you wouldn't ask a pit bull to look like a Chihuahua. Genetically, that is a huge factor and based on our body shape and size. I try to avoid mirrors. Well, I think mirrors can be very activating and or triggering, especially because there's the distortion of like how a person may or may not look, like if they're in a department store versus I have several clients that are professional dancers and they speak about how they're in front of the mirror all the time dancing with their companies, and that's very, activating. And for, those people that are not, in that field, I mean, I think really being able to have a mirror that's like from, your chest up, like, okay, I can wash my face or apply makeup or, use the dental floss, etc. versus like, what purpose does it serve to have like a full length body mirror? Another danger sign could be when an individual will only meet someone for a beverage, a coffee, a tea, a chai latte, where it's like, no, I can't meet someone for food. And the other thing, and this has again been normalized too, is that I'll only go out to eat if I know everything that's in the meal. Like I can look it up online and get the nutritional information. Again, this has become just the norm in our society. Being that I'm in Los Angeles, I hate to say, I mean, people talk about plastic surgery all the time. And I would imagine it's in other, the country as well, but it's really become a thing, especially as I've heard clients over the last 2 years with COVID, where it's like, well, I don't have control over what's going on in the world or, pandemic, politics, et cetera. But, oh, I think I'm going to have, liposuction. I think I'm going to, it's sort of like, it becomes a hobby. It's something to do because they want to try to fix themselves externally as opposed to working on themselves internally. Another danger sign is, believe it or not, individuals that struggle with body imaging disorders spend a lot of time thinking about the types of colors, prints, designs that they feel they can hide themselves in or that create a different facade or image. That is a warning sign. The constant comparing yourself to family members, to friends, to siblings. It's like you could come from the same parents, you and your sibling, but have totally different body shapes and sizes. And it's sort of like, the radical acceptance, accepting things that you can't change. It's like, okay, I'm someone who has hips, but, my sister is someone who has, no hips. So again, the comparing, like, where does comparing get you? And where it really affects moving forward, just your overall well-being. Another warning sign is asking people who have lost weight, like what their secret is, because there's so much talk regarding every diet trend du jour. And again, it's like, you don't know if they have an eating disorder, but again, there's so much focus and thoughts on that as well. Based on diet culture, when you hear people say, well, I'm only going to be paleo or organic or gluten-free or vegan, or I can't eat at this time. Now I've heard literally in the last 2 weeks, at least a handful of people talking about intermittent fasting. It's like there's always a trend, a food. And again, we've just accepted it. Like, this is what people talk about and think about. And that's actually a warning sign. Of course, then when people, kind of going back on the restaurant front, where if they don't know what's in the food, or it's like they'll only eat at a restaurant that's organic. Engaging in laxative abuse, diet drinks, diet teas. People don't realize actually that there's so much involved in that can contribute to them, messing up gastrointestinally what's going on, but that is a warning sign. Diet bulimia, exercise bulimia, diet bulimia is one too, but exercise bulimia, where a person feels guilt or shame because they feel fuller, or they ate a food that they view as forbidden. So they're exercising, they're moving versus learning how to sit with that fullness. I was going to say, and this is a sign, diabulimia, for individuals that have diabetes that are on insulin. This is not on the slide. I just kind of rattled that out earlier, where they are skipping doses of insulin because insulin makes a person what's called insulin resistance. So this is an eating disorder and a warning sign where they're altering their insulin dose, because when they're insulin resistant, oftentimes their weight increases. Another warning sign is restriction, like, well, I'm going to a big dinner tonight. I'm not going to eat lunch today. Or I'm just going to eat something very small because I know I won't be able to control and regulate what's happening later. That is a warning sign. And again, I think what happens is oftentimes we make light of these different things, but not realizing how much time during a 24-hour waking hour day that an individual is constantly thinking about what they're eating, what they're not eating, how much they're moving. I mean, there's so much emphasis and it's cluttering their mind. I mean, I've discussed with clients, like, out of a 24-hour waking day, like, how many hours do you find yourself, thinking about food, body, movement? And it's very unfortunate. And you think about, well, gosh, it's like most of my time that I'm awake. I binge eat and I deprive myself of my favorite food. So that typically happens when we restrict and deny ourselves. That will set us up to binge. And that is a danger sign. When an individual has shame in food, or shame in liking food, or they're afraid to like food, they feel like that privilege has been revoked because perhaps they live in a larger body, or they've been fat shamed or bullied growing up, or by a healthcare provider. They feel like, well, I don't deserve to eat food that I like. And that's a problem. That's a trauma. When they have shame in their body, another one could be that they can't be intimate with their partner unless he, she, or they are in the dark, and or he, she, or they doesn't look at their body. So when I see clients in person, and it's been, totally different, over the pandemic, one of the things, and it's been really hard to see it on Zoom versus in person, there's a term called Lenugo, and Lenugo's known as peach fuzz. You see this fine hair on babies. When an individual is malnourished and they are basically in this fight or flight syndrome, on the sides of their face or on the rear parts of their shoulder, they develop this hair. And individuals will oftentimes think like, oh, I'm just going to get it lasered or waxed or whatever. It's like your body is in starvation. And this is your body's way of trying to survive. So like when I'm seeing a person who's medically compromised, who is malnourished, and we are working on nutritional rehabilitation to reintroduce food back into their diet, believe it or not, the Lenugo naturally goes away. So you don't need to be waxed or lasered or tucked or plucked. It's like as a byproduct of your body being in survival mode. So for those of you that work with clients face to face, it's always just a good visual to have and see. And I think I will just say what's been super challenging is then, of course, with the masks, seeing people with the mask, like you can't see their face. And now, when I was seeing everyone come in the Zoom room in different countries where it's snowy and cold, probably people are not coming in short sleeves and tank tops. I'm in Los Angeles where I'm embarrassed to say, it's cold here today. It's maybe like in the 50s, but it's all relative where you live, right? So right now it's like, I saw someone yesterday and she was in her short sleeve, and I was like, okay, I could see her, peach fuzzy. She lifted her arm a bit because when I was taking her blood pressure a little bit, but it's harder to gauge now is more my point, but I wanted everyone to know what that actually looks like. Another that's very, very important, this is called the Russell's sign for individuals that purge. So on their knuckles, there are these calluses that have developed, as well as oftentimes those Russell signs you could see on the knuckles, because if they're not sticking their finger down all the way, or there's individuals who purge that use a toothbrush or a pencil that may not have that, in addition to if they have purged so much, their gag reflex has diminished. So you might not even see that. I don't think I included this other slide that basically shows the chipmunk cheeks from the parotid glands being swollen from purging. But these two are the most apparent, like when you are sitting with people that you can see. And in fact, when I have been, as I said, right now, I'm still like 95% virtual. A month ago, I was like 60% virtual. I would be creative on Zoom, like asking people to show me their hands, or to be able to, like the next slide, which I'll talk about, the capillary refill time. I would do these things, people, but again, it's hard to get a true representation on Zoom. And especially, you might say, I don't feel comfortable like asking or looking. And to become an eating disorder trained expert, I mean, it's been over 2 decades in the making for me to get to the level that I'm at. But I think the one statement I would say is like to be able to just really try to be observant the best you can with whomever you are sitting and having a conversation with. And again, with the masks, it's hard to see on the face. This is very important, a capillary refill time. So a capillary refill time is a blood return. So like when I see people in person, I'm going to stand actually and demonstrate. So like I'll ask clients to squeeze and hold their fists for 10 seconds and then to open. And you see like in this photo here, like the fingertip is very white. When it returns fast, like when the red comes fast, that's great. That's a reflection that their nutritional status is not compromised. But typically with the folks that I see and that are having some sort of challenges, you can see that it stays white for a while. So we usually do it in their fingertips, in their hands, or the tops of their feet. Like I would have clients take off, their shoes and socks. And this is just important to know about. So that one of the best parts of my job is seeing that capillary return get faster and faster. And like the other day, my one client, like her right hand was coming back faster over her left hand. She's like, Robyn, when I met you, I remember they just would both stay white. So that's, again, a visual that you can see too with your clients. So I wanted to talk about, there's these various meanings of quote unquote normal. And I actually talk about this in length in my book, actually. So, regarding, BMI, and we'll, let me just see if I forgot if I have this slide. Okay, yep, I do. So let me just go back. You know what? Oh, here we are. Okay. So yes, I want to talk about Bmi Labs, the blood work, which is important, and a person's appearance, because there's, so many mixed messages on both. So BMI was developed in the 19th century by a Belgian statistician for groups of men. It was never developed for individual people, let alone women or anyone. It's very archaic and outdated. It is something that does not take into consideration a person's body composition, their nutritional status. It doesn't ask, comprehensive questions about a person's relationship to food in their body. It does not evaluate a person's mood, their sleep patterns, hormonally where they're at. And it does not take into consideration their overall well-being. Only it's a measurement of height and weight. So any trained eating disorder provider would use, in lieu of BMI, it's called the SCOFF and the Eat 26 eating attitude test. These are, and I actually have them in detail in my book, actually. So I just wanted to say, because this is something I always talk about with clients, how unfortunately, if you go to your doctor, many doctors still are using the BMI, and it's very triggering, activating, and stigmatizing. And I want all of you to know, like, you know what, when you're babies, it is predetermined what your body will look like as you age. So if a person's having to go through unnatural and extreme measures to change their body, then it's probably not the place where it's naturally meant to be. So I always like to say, you know what, like when you're going to the doctor, I actually have a handout that a colleague has created. So like the research shows that individuals will either stop going to the doctor or they change multiple times because they feel ashamed and embarrassed based on being judged and ridiculed based on their body shape and size. So unfortunately, providers don't realize, you know, our genetics, our culture, foods we've been raised on, our trauma that we've experienced in life, hormonally. And I just really wanted to emphasize how BMI is problematic, and there are many other effective ways to evaluate a person's physical and emotional well-being. Now, when we talk about normal, what is normal? So there are many levels of hunger and many levels of fullness. And actually my last client, he was asking me like, oh, what fullness level is normal to reach? And I said, well, maybe to think about, like, one of his goals for this next week was to look at, like, well, what fullness level do I like to reach? What feels satisfying to me? You might say, well, if I have a long time before I can break for the next time eating, I like to be a little bit fuller, as opposed to before going to bed. Maybe I don't want to feel that level of fullness because oftentimes I'll have indigestion, heartburn, and it affects my sleep. So really understanding what works is what works best for you. There's no quote unquote right or wrong way. And I always like to say each person is an individual in regards to what feels satisfying, like what hunger level they like to reach, just like what fullness levels they like to reach. And they are constantly changing. So there's times we overconsume and there's times we underconsume, and we trust our body will make up the difference for it at the next meal. So that is important to look at. And I want to say with quote unquote normal, you know, we hear this time and time again, like, oh, your labs are normal. So like, even we talk about misinterpreting normal due to BMI. I mean, I have, you know, a client who's a professional athlete, and he's like, Robyn, for years, the doctor would tell me I'm quote unquote overweight, the term we like to use, in a larger body. I was like, you're all muscle. And the problem is when providers are using BMI, then that's how they're viewing if a person's normal or not, which is false. Whereas with blood tests, so the thing with blood tests is they don't always disclose everything to us, which is why I like seeing clients in person, to be able to take their vital signs when I'm seeing them, you know, week to week, because your blood pressure changes, your pulse, your capillary refill time, blind weighing, which we'll discuss. And again, lab tests could take time to change. Like when a person's really going downhill, then they will change, but it could take months to see that the labs are off. And I've had so many clients, and I do have many clients that fall through the cracks with their providers, because it's like, oh, you're normal. And like, I have a client who quote unquote looks normal, and she has it's called atypical anorexia nervosa. And what that means is she's a person who lives in a larger body. This is just like her shape and looks normal. And she's been like restricting for a long time, and her hair is falling out, and she has all these bruises on her legs. And her doctor's like, yeah, that's just your body. And she's like, Robyn, I could never tell him that I restrict. And so the problem is when a person does not look ill, then oftentimes they're kind of pushed aside. They're like, oh yeah, you're fine. You don't have a problem. It's until the labs, the blood work actually is shown off, is shown in a, you know, then it's showing that things are off. weight cycling, this is important to be able to understand. So like individuals that are chronic dieters that have various food rules, weight cycling is also known as like people that yo-yo diet. And the more that we weight cycle, again, it may or may not be reflective in your blood test, but understanding how weight cycling is an indicator for developing an eating disorder. 1 out of 3 people that diet will develop an eating disorder. And understanding that even if you're like, oh, I don't have an eating disorder, I'm always on a diet. If you're always on a diet, you most likely have disordered eating, let alone its transition over into an eating disorder. Weight stigma. This is, I would say, the most traumatic of it all. Weight stigma in healthcare providers where they perhaps have furniture that are not geared for all different body shapes and sizes. They don't have blood pressure cuffs that encompass people in larger bodies. They have, in their building, their restroom is not to accommodate someone in a larger body. So weight stigma is like perceiving, like in our society, you need to eat a certain way to look a certain way to have the specific outcome, which is false, and that is traumatic. So, the problem with weight stigma is it is fat phobic and it discriminates against people in larger bodies. So that is the term we like to use in my field. There's people in larger bodies, just like there's people in smaller bodies. Trauma, which I think is so, so important and unfortunately is not asked upon of providers, other than I find different mental health care providers I work with that specialize in trauma, but it's oftentimes overlooked due to lack of just knowledge, training, and information. And that certainly shapes the choices a person makes, does not make, how much, how little, and just how their relationship with food and their body has evolved. Restriction, it's another, tough area when, you've been bullied, you've experienced some sort of, trauma in your life, or you've been a chronic dieter and you're like, okay, I feel like my restriction has allowed me to survive through the toughest of times. And these are all terms that I really encourage all providers to become acquainted with. And there's a lot of great information out there to read about it. But again, it's not, you can't look at a person and determine if they are quote unquote healthy or unhealthy, or if they have an eating disorder or not. You can't look at a person and determine if they're at the place where they quote unquote should be in their body. And there's been so much built up on that, which has created the damage that has been done with, I would say, many of the people that I work with. So for the term normal, so the appearance bias impacts treatment. So again, we all have biases, and whether a person believes that or not, it's like there's a great survey through Harvard, implicit bias. So we'll assume like, okay, a person looks a certain way, oh, they must eat this way, or they don't take care of themselves. And in 2014, there was a study in the International Journal of Eating Disorders that found that 35% of clinicians reported feeling uncomfortable caring for larger bodies. 56% observed negative comments while caring for people in larger bodies, and 29% reported colleagues having negative attitudes towards individuals in larger bodies, and 42% believe that even certain clinicians have negative stereotypes pertaining to individuals in higher weight bodies. And I just want to say that if you want to work with eating disorder providers, it's crucial that you do your own work on your own biases, because clients are savvy and sophisticated. And if you're someone who's not comfortable working with a person in a larger body, or you're like, oh, I'm on this diet, that stigma, that shit will come out, and it will not be a happy, successful story. So it's always suggested to be able to work on your own biases and supervision on this. This is you guys. How to support your clients at the Scottsdale Youth and Community Coalition. So realizing, there is a problem, and be willing to refer out to create a treatment team. And, one of the things is like, there's enough business for everyone. And if you're afraid to refer out because you feel like I'm going to lose this client, realizing like you could be doing more harm or damage. And I know it's not intentional, but it really, I think, is the professional integrity of a provider to say, this is out of my scope of practice. I am not trained in, eating disorders, body image. It's like, I was speaking to a clinician the other day who referred someone to me, and the client is really out of her scope of practice. And she's like, oh, Robyn, I worked in addiction for, some time, and it's very similar. I was like, no, it's not. This is totally specialized and requires really formalized training. And then the other thing is, I'll hear someone say, well, I had an eating disorder and I'm recovered, so I think I'm sufficient to be able to work with the individual. But I just want to say that it's really in the best interest of the client, because I would say the work we do is really to be in the best interest to help people. We're in a service industry, and we want to be able to make choices that are going to help the client, because my goal with anyone I see is for them not to need me. I want them to have full, thriving lives. So with that being said, if you are not an eating disorder therapist, perhaps refer to a colleague who is. Also, so a registered dietitian, we are now RDN, so we're called Registered Dietitian Nutritionist. And so I am what's called a CED RDS. So through IADEP, which is the International Association of Eating Disorder Professionals, they offer a eating disorder credential for mental health care providers, for physicians, for therapists, dietitians. So I am a certified eating disorder registered dietitian. That is this credential / supervisor. So I train and mentor dietitians, therapists, anyone who wants to become an eating disorder specialist. And oftentimes I am a part of a team where I am the only eating disorder provider. So that's why I was saying, like, if you're like, well, I have a good relationship with this client, they're uncertain, about going to someone else, and until I can bridge that gap to refer to a provider that would be better for them, at least have an eating disorder trained dietitian on the team. Oftentimes I'm the one who's navigating the whole team and teaching everyone. That's fine, but I think it really depends on the severity. Also, being able to have a psychiatrist that specializes in eating disorders, that's difficult to find, just like physicians that are eating disorder trained. We don't have a ton in Los Angeles. There's like a handful, and we all refer to those same people. But I just wanted to say, I have on here that a registered dietitian nutritionist who is a nutrition therapist. And what that means is someone like me helps clients connect their feelings centered around food, versus you would not want what's called a traditional or weight normative dietitian, a person that's talking about calories or putting them on a diet or on a meal plan. I mean, certainly I'll begin with more structure and hand-holding and guidance, especially as we are nutritionally rehabilitating a person. But you really want someone who is an expert in this, because these clients are so complex. And I have resources on here how you can find someone like me too. And I think it's really important to emphasize to your patient that you're not abandoning them, and that you're there as a part of the team, and you really want a team that's going to be in the best interest to help. So making sure that the client has had a recent physical, and in this physical, I find, and I actually have this in my book, all the specific, blood tests, and actually through the Academy of Eating Disorders, which I have in my resources, which I'll talk about, they have a free pamphlet that talks about the labs that are important too, because time and time again, I'm giving a sheet to clients from when they go to the doctor. These are all the blood tests I would like for you to have done, in addition to a bone density and EKG. But the problem is, even if they're having the sheet and they're asking their doctor to draw it, if they are not savvy and an expert with eating disorders, they're not going to know, like, they'll say, oh yeah, your blood sugar is fine. Well, you know what, this blood sugar is chronically low because they're malnourished. They're not going to, something could look normal, but they're not going to see the pattern like, oh yes, you know, their white blood cell count is low due to malnourishment. And I see the last few times I've drawn that. So that's why you really want someone that's an expert, as I would say, like if you had, you know, a loved one that had cancer, would you stick with your internist or would you go to an oncologist? You'd probably go to an oncologist, hopefully. And that's the same thing with, you know, when there's an eating disorder, you want someone that lives and breathes this. Like I say to my clients, you want the doctor version of me, you want the therapist version of me. And I talk about that extensively in my book. And I really hound that to everyone that I see, because time is of the essence. And when people just kind of push it or say like, oh, they'll outgrow it. The last 2 years, I feel like every call is a crisis. It's like everyone is so sick. Oh, I didn't see the warning sign. Oh, I just thought, you know, my child wanted to eat healthier and they were eating more salads. It's like not realizing, and it might start out innocently and then it just escalates too. Also in the blood work, being able to make sure any competent eating disorder trained physician would have what's called a CMP, a complete metabolic panel done. And what that is, that's like your glucose, your sodium, your potassium, your chloride, like your basic labs that are done. Also, the amylase and lipase. So if an individual has a history of bulimia nervosa, their serum bicarbonate. So if the value is greater than 38, that's due to purging, and normal is 22 to 28. So if a person says like, no, I don't purge or I haven't purged, like your labs don't lie, basically. For individuals, for women that menstruate or are striving to menstruate and they're not menopausal, having their estradiol be greater than 100, because a woman who's in menopause, her estradiol is less than 34 and a male could be up to 56. And like from a male perspective, it's basically, and I will ask this with, you know, male clients that I see, if, you know, because it's like common, you know, a male will wake up in the morning and they have a hard on. That's just what it is. But when they're malnourished, they are not. So definitely the estradiol, let alone their testosterone, could be off too. And I think too, understanding that labs could be normal. So again, that's why you really want doctors that get this. And also I have on here, because often there's dual diagnoses. There, you know, an individual has an eating disorder, but it came up secondarily as they were in their sober living. And, you know, having a team that like works with addiction and eating disorders, I think it's nice to be able to have both. Very important websites and resources I want you all to know. So the Academy of Eating Disorders, which is AED, I had referenced that before. So the aedweb.org is the free little purple manual that's literally like the snippet of blood tests, and it just touches upon, I think it's very important for you all to have on your bookshelf. NEDA, the National Eating Disorder Association, NEDA.com. I mean, that's like the layman person, but I think it's good to be able to have NEDA because they have, you know, resources available. IADEP, which is the International Association of Eating Disorder Professionals. That's where my eating disorder certification's through. So IFED is the International Federation of Eating Disorder Dietitians. So I'm the Los Angeles ambassador for IFED, and anyone who's an eating disorder trained dietitian is on IFED. So that's a very important resource to have. You could type in your zip code to find an eating disorder dietitian in your local area. My book, of course, The Eating Disorder Trap, a guide for clinicians and loved ones. It's written in a very basic manner. You do not have to be trained in this. Purposely, I wrote a book that anyone could read and understand because I didn't want the typical reader to feel like they had to have a PhD in science or eating disorders to get this. So it could be your neighbor, your gardener, your nanny, anyone can read my book and understand it. The other thing that's very exciting, I actually have this on here with the link. So February 21st is the launch of National Eating Disorder Awareness Week. And I have an online course coming out with my colleague. We've been working on for 6 months. It's called Your Recovery Resource, a program for navigating your loved one's eating disorder, which I have a picture of, which will be on my website, which I have on here. And is literally, we're so excited because there's nothing like this in our field that can help the layman person who has a loved one who's struggling. So this is my book, The Eating Disorder Trap. This is my online course. The button is not on my website yet. It will be February 21st, Your Recovery Resource, a program for navigating your loved one's eating disorder. So the great thing about the online course is you can do it at your leisure. You don't have to do it in order. We have videos, we have exercises. My colleague Becca Clegg and I, who's an eating disorder therapist in Georgia. This is our baby that we've been on for the last 6 months. And the other thing I think that's so important. So Clear Step is the first numberless HIPAA compliant scale. This has been a game changer. I'm trying to move this bar, everyone, because it's blocking mine. There we are. So this is fantastic because many people live far away. They can't see providers regularly, and having a numberless scale has been fantastic, where it's not straining a relationship, it's not triggering them, and all their information comes in my computer. So it's anxiety free, which is great, saves time and money for the client and clinician, making appointments, going places. So for virtual, it's great, but I think even non-virtual as well, especially if a person's living at home and the parents have been quote unquote blind weighing. Also, it's in real time. So that's great. If you were like, hey, Robyn, you know, for our session today, I just went on the scale, so I'll know what's happening. They have a portal. It's on your cell phone. It's easy to, you know, create reports. You can have it in many locations. You just need batteries. So with ClearStep, so their website, clearstep.com, and for everyone in the conference today, they've been so generous to provide a 25% discount code, promo code Robyn, capital R, Robyn G, 25% to save 25% off. And I highly recommend it. It's helped my practice these last couple of years, and I'm so excited about it. And they actually now have a blood pressure cuff that has just come out too, because oftentimes clients have, you know, anxiety, white coat syndrome with the blood pressure cuff. So that's available as well. And this is me and my website, askaboutfood.com. And I'm on Instagram at Robyn Goldberg RDN. And I have a podcast as well, the Eating Disorder Trap podcast, with topics I think are very relatable. Each episode's 15 to 25 minutes with many of the top eating disorder experts in the country and some clinicians that are non-eating disorder that I've worked with that I think have a lot of golden nuggets to share. So please feel free to check that out and subscribe as well. And look forward to hearing questions that everyone has.
Robyn, that was fantastic. That was so interesting. And I was literally bombarded with questions. So let's get to them, okay?
Okay, great.
The first one that came in is, do you think there is a higher rate of eating disorders in the Beverly Hills area compared to other areas of the country, or about the same or lower? And I would like to add on to that question, looking at the US versus other countries.
So first of all, I think all large cities, Los Angeles, New York, San Francisco, Scottsdale. I mean, I feel like larger cities, there's more disordered eating, let alone eating disorders. I mean, granted, LA, there's, you know, Hollywood, entertainment. Of course, I think that adds to it. I always say I live in the land of eating disorders. I mean, it's just what it is. But I can tell you, because my husband and I have been all over the world on a bike, and I always ask, I have always like 3 controversial questions I always ask, one of them about, you know, body image and eating disorders. And I can tell you in villages in India I was in, and, asking this, it's like, we're just trying to get a meal a day. So I think the larger the city and the more materialistic things, the more body image and eating disorder issues there are. And just to mention to you, Rachel, you said, in the United States, it's everywhere. It's rampant. I mean, I have colleagues in Nebraska or North Carolina. It's everywhere. And everyone that does what I do, and I'm on so many listservs with all my iFed user dietitians, and I see these emails all day, every day. Durham, Durham, Raleigh, North Carolina. I mean, it's everywhere. Oregon, Portland. I mean, it's like, it is everywhere. It's like the termite infestation is like, internationally known. My colleague, who's the only eating disorder dietitian / physician in the Dominican Republic, is drowning. She and her team, they're the only team there. So it is everywhere. It is a global problem.
Thank you. I'm going to go in order. Some of these have a similar theme, but I'm just going to go in order because there's so many of them. Someone asks, I have always been told that it does not matter what time of day I eat. Is this true? If not, when should my last meal be consumed before bedtime?
This is true. It does not matter what time you stop eating. Your stomach does not know how to tell time. As long as you are breathing and living, your metabolism is working.
Great. How do you balance fit gym culture with the idea that pushing through pain while exercising is part of diet culture?
Just again, pushing through pain at the gym. Say that one more time, Rachel.
So with the idea that pushing through pain while exercising is part of diet culture, how do you balance the being fit and going to the gym and exercise and pain is what I'm getting from
So a couple of things I want to say. So I was a former college tennis player and a triathlete for 6 years. And I had my first foot surgery when I was 13. Unfortunately, I think my chronic feet problems, part of them are genetic, but I used to work through the pain, and I'm paying for it now as I've gotten older. So looking at what kind of joyful movement or intuitive movement do you enjoy and what feels pleasurable to your body, as opposed to thinking you have to do a HIIT workout and something that's going to be this just high intensity type of training, to say, what kinds of things provide pleasure to me? What nourish my soul? What helps to clear my head? What feels enjoyable to my body? Maybe approaching it that way versus, the gym environment can be very toxic and it just feeds into diet culture.
Thank you. How do you balance food allergies with an eating disorder?
See people with it all the time. Well, so if it's a true food allergy where it's documented, I use an EpiPen. I think that's important to look at versus, I have a food intolerance. I always like to say, whether you're working in treatment or not, I want the documentation. So I think that's the first part, and knowing, yes, if you have serious food allergies, then a person's going to not eat the specific foods that are going to send them to the emergency room, but really looking at if it's a preference, if it's a fear, if it's avoidant, if they're, conflicting messages they've heard regarding various foods, and I would need to dig deeper on that.
Okay, thank you. Regarding Lenugo, does the body hair have to be white if you typically have dark hair?
No, it's peach fuzz. So if you're, like I was discussing with my client the other day, who's Iranian, and she was like, I'm just hairy because, I'm Persian, but also with my restricting, the hair accelerated. So no, it's seen usually as the white or lighter hair, but it can be darker hair.
Thank you. Are there assessment tools other than SCOFF and EAT26 that are not based on white bodies as the majority?
Great question. Well, and I just want to say, actually, in my book, I had a colleague of mine who's transgender go through my book to make sure that there were gender affirming pronouns implemented, and being able to I have illustrations in it that are non-binary and all different skin colors and nationalities. And yeah, you know what? That's a great question. I don't know any tests. Yes, because those tests were developed on people that look like me, basically. So I think, I mean, there's great books that I could suggest, but not actual assessments. I think the questions I have in my book, a lot more, is where I would actually start.
Interesting. How does trauma, especially in childhood, affect your eating patterns? How does eating affect individuals that are diagnosed with borderline personality disorder?
With trauma, well, first of all, oftentimes an individual, they, excuse me, they eat to soothe or suppress any kind of negative feelings based on the trauma they've gone through in their lives. You know, what was the question with borderline personality disorder?
How does eating affect individuals that are diagnosed with borderline personality disorder?
Yeah, I think maybe the personality change, but it's not affected the way like the trauma, where it's like, yes, you know what, if I'm having a flashback about, you know, when I was raped or I was beaten, it's like then a person's eating the specific foods that are soothe themselves. Like I'm, you know, experiencing that with several clients now, but I have clients that have, you know, BPD or bipolar and, you know, schizoaffective disorder. And I think it's all just sort of wrapped up into what their relationship with food has been like and that persona that they're projecting at that specific time.
Okay, thank you. I am struggling finishing my food and getting full easily. This has caused me to undereat most of the time. What would you recommend to me?
Good question. So when a person's at a lower body weight, when they're at the place that they're not naturally meant to be at, they can trust their hunger, but they can't trust their fullness. So it's true that your capacity has diminished in regards to the amount that you're able to eat. And there's what I would call no shortcut to work through the pain. And my first question is like, do you have an eating disorder team, a dietitian, someone like me that you work with that can help you work through those challenges? Because like one of the things that I do with clients is when we're like, it's called Recovery Record. It's an eating disorder app or Rise Up. And when I'm seeing what they're doing and then we're having our session, I'll say like, what would it feel like if we reduced the amount of the vegetables of that meal and we upped the rice to see what that would physically feel like? Because it's going to be uncomfortable, however you look at it, because your stomach, your capacity has diminished and it's not going to feel comfortable. Not to mention, I would imagine that you're experiencing constipation or you're not evacuating, empty out as comfortably as you have had in the past. And as your weight increases and as your nutrition changes and increases, that will feel better for you too.
I know that later in my list, there's a question about how to find an eating disorder specialist. I know you provided resources, but do you have other suggestions?
I mean, those are it. I'm giving you IFED, the International Federation of Eating Disorder Dietitians, IADEP. Those would be.
Okay. What factors?
Sorry. I want to say also I'm forgetting the name. I'm gonna have to look because I advertise on several of the websites. There's eating just I'm gonna look it up on the phone actually. I want to say, hold on, something fishy. There's a few. Why don't I remember here? Let's see. Sorry.
We can always send that out later too if you want to.
Okay, sure.
There's always some follow-up to go along with it.
Okay, sure.
So interesting. Okay, our next question for you, Robyn. What factors would be off in a standard blood test that would indicate an individual has an eating disorder?
Their phosphorus.
Okay.
That is that is indicative that they're malnourished and they're needing to go through refeeding. I mean, there's so many. I mean, it's not just one. I mean, their potassium, their chloride, their sodium, their glucose. I mean, it's not one. There's many. Their white blood cell count, their estrogen, their testosterone, their iron. I mean, there's many.
Do you use functional lab levels versus the lab ranges?
What do you mean functional lab?
I don't know. I don't understand the question, so I'm not sure. If the person who asked that wants to put that in the chat, we can follow up with that towards the end. What are your recommended strategies for teens with Arfid?
So Arfid is avoidant restricted food intake disorder. Definitely want providers that are trained in Arfid, and this is a long process. I mean, they all are long, but with being able to work on the exposure therapy of introducing various foods and how that's incorporated. Oftentimes they've experienced some sort of trauma, which led to them developing Arfid. But I find with the clients I see that have Arfid, those that are teens that I'm actually seeing, having the parent in the session, I find it is helpful. Like part of the session I'll have with the client and then with the family member as well. And I have an adult who has Arfid, and I think it's harder with him because I think he's had it for way longer than before it was actual a diagnosis. But it's definitely the exposure therapy.
There's follow-up. Thanks, Elizabeth. Functional is how it reacts in a body of your health size versus the lab ranges, which each lab creates and has their own
range. Okay, so the question was how blood work, how labs respond individually in a person's body. Read me the question again, Rachel.
So the question is, do you use functional lab levels versus the lab ranges? And the follow-up to that was, functional is how it reacts in a body of your health and size versus the lab ranges, which each lab creates and has their own. Functional medicine doctors use these types of labs.
Oh, functional medicine. Yeah. I mean, in the eating disorder world, it's really not been researched and explored to see, because I don't know any eating disorder trained functional medicine doctors. And the functional medicine doctors have their own labs they use too, just like the Western medicine doctors as well. So, and the ranges with these different labs might be off 5-10 points from lab to lab, but they're all in the same general range.
Okay. What about people with darker skin for capillary refill? And can you explain what can you explain what capillary refill is?
Yeah. No, I have people with darker skin, and still the red, the flushing, the return when they're squeezing their hands, it still is not return. It's like, they might be a darker skin, and then there's still that lighter part on their hand versus, I'm thinking of a client I see, and when her father will come in and he and I will do it, and so they're people of color, and she's like, oh yeah, look how it is on my dad. So yeah, it's just a different shade of your base color of your hand as opposed to someone that's Caucasian.
Thank you.
Because we all have that blood return, no matter how dark or light we are within our skin.
Please, what is the cause of eating disorders and how can it be managed beyond the clinical solutions?
Well, I mean, it could be genetics, there could be trauma, diet culture, messages, in our family history. I mean, there's so many, contributing factors. And how can it be managed? Telling people to stop diet, telling people to, eat a certain way, all these messages that come out for the beginning of the new year, and really breaking away from, BMI and diet culture and fat stigma.
Okay. How do we differentiate ED between an eating disorder and erectile dysfunction?
So I'm sorry. So I use the term you're saying ED is eating disorder and versus erectile dysfunction.
Well, the question, I am thinking that this is referring to when you said that when a man wakes up,
Yes.
he has a heart on, and how do
Yes,
you
yes.
how do you differentiate those two? I think.
Well,
It's
if you're 13 years old, chances are you don't have erectile dysfunction.
mm-hmm.
And
Mhm.
I'll just say, like, I have clients that are adults and they're like, you know what, I'm not eating carbs, I'm not eating fat, and they don't have erectile dysfunction, they are malnourished, they have a lack of nutrients.
Okay, thank you. Is it safe to say that most clients with eating disorders have some trauma in their past, or is there a statistic about that frequency?
I don't have a statistic on hand. I wouldn't say most, I would say many. I mean, I have clients that don't, but I feel like the more and more people I speak to, you know, after doing this for over 2 decades, I'd say more and more people have some kind of trauma, and trauma is all relative, right? Each person's trauma is different from another person's trauma.
Mm-hmm. Okay, thank you. What about clients who don't show the traditional eating disorder behaviors, but have a clear weight loss and complain about discomfort after eating? How do we differentiate between a medical and an emotional or mental issue?
Having them evaluated by someone like me that's eating disorder trained. Again, I put screening questions that are just some, I mean, I touched upon this. I mean, you're not going to become an expert over an hour, but there are so many questions. If this person was evaluated by an eating disorder trained physician or eating disorder trained dietitian or therapist, then it would be confirmed. And yes, it's common, of course, that a person would feel fuller and uncomfortable just based on the transformation that their body has gone through.
Okay, thank you.
Really quick, Rachel, a follow-up quick to our last question regarding the ED, erectile dysfunction versus eating disorder. We did get a follow-up from the person that asked that, and they said kind of, no, it's more in, I think, how it's referred to. And so like the fact that it's referred to as ED, both of them can be. Is there any differentiator between that, whether it's how somebody like verbally says it or how it's maybe written on paper, I imagine is probably where that's kind of going. Is there anything that you can speak to regarding that?
Wait, so Jordan, you're saying just the initials ED?
Yeah, just like capitalized initials ED. Like if you were to come across that.
Yes, that's how I
writing.
write it. And you know, I know it's like, so anyone in my field when we write, yeah, so that's, we do, but I think clarifying which one it is, it's like, you know, saying CPK and like, oh, California Pizza Kitchen, no, creatinine phosphokinase, you know, in a lab. It's like the same, you know, it's the same thing. So yes, there is that confusion. Like, you know, my credential, you know, through the Academy of Nutrition and Dietetics, we used to be called ADA, which was the American Dietetic Association. And people would say, oh, American with Disabilities Act or the American Diabetes Association.
Yeah.
There's just, yeah, it's what
So
it is.
it's just one of those things where you're going to have to really pick out of context what
Yes, yes.
Okay, I think that helps answer the question more.
Thanks, Jordan.
Yep.
Thank you.
In the beginning of rehabilitating the patient's nutrition status, you said you provide more structure. Do you ever utilize food exchanges? If not, can you describe what you mean by structure?
So I don't work in a treatment center. Treatment centers, and they're all different. Some provide exchanges. I find in my practice, I don't, because it gets a person fixated more on the counting, since many of my clients are so perfectionistic and rigid. And I like to be able to say, well, let's see what, if you're having a fistful of this or 2 fistfuls of that, or because many of them are already obsessed with counting and measuring and weighing, and it just can heighten that people.
Thank you. This is a question about residential treatment. How do you balance dual diagnosis treatment with an eating disorder that pops up when a person is in residential treatment?
Well, you know, ideally, and if I'm understanding the question, they would want to be able to go to a residential treatment center that specializes on the eating disorder and whatever, you know, if it's trauma, if it's addiction, but not one that I would say that's eating disorders light, where it's like, this is an eating disorder trained treatment center that does work with addiction, that does work with whatever that other secondary diagnosis is. So I'm not sure if I answered the question with how to balance it.
Well, it looks like if someone is in a residential treatment facility and then they discover, wow, they have an eating disorder. How do you balance that with a dual diagnosis? Or how?
I don't work in a treatment center, so every treatment center will be different with how they manage it.
Okay, thank you.
I'm in private practice, yeah.
Okay. This is about the clear step scale. What values does the clear step scale measure or report?
The clear step scale currently is just a blind weight. So that is basically what its purpose is right now. They have another, they have a blood pressure monitor cuff, but so you could put notes like on when I'm looking on my computer and I'm putting it in, I'm writing notes, I'm seeing trends, there's graphs, but I don't get into right now. They're in the process of looking at other things to be able to add to it, but it's strictly a scale, a numberless scale.
Wonderful. Somebody asks about how magazines and television play a big part in eating disorders, and if you could speak to that.
Yeah, I mean, that's diet culture. Social media is out of control with, it's not realistic. There's so many altered images and inaccurate descriptions of how people are truly represented. And yeah, I think these last years, people are spending a lot more time on the screen, and that has certainly been harmful towards their body image and eating disorder issues.
Mm-hmm. Thank you. Sometimes the lines between unhealthy eating patterns and binge eating can be hard to distinguish. How do we correctly diagnose clients and patients with a binge eating disorder if they are maintaining a healthy weight?
Well, they could have what's called, they can have atypical anorexia nervosa, but also, yeah, you can't look at someone and say, oh, they look quote unquote healthy in their body. I was on Zoom with someone yesterday who looks totally normal. And when I saw her 2 years ago, she was not someone who struggled with binge eating disorder. So, and I will say binge eating disorder is the most common eating disorder and the least spoken about. 60% of women who struggle with eating disorder struggle with binge eating disorder, and 40% of males that struggle with eating disorders have binge eating disorder. So it's the most common and the least spoken about.
Someone's asking about
sorry, 1 second, Rachel. I want to make sure we don't forget. Sorry, I accidentally cleared one of these questions on accident. To what extent do you advocate for medical marijuana to help increase appetite?
I'm not an expert on medical marijuana. That's not my area of specialization, so I'm probably the wrong person to ask.
Okay.
How about recommendations or suggestions you can offer to parents of children with special needs who may not feel like eating or have shown a decrease in appetite?
I think they need a specific team that's trained with individuals that have special needs, because it's important to evaluate the entire person and make sure everything is okay.
Okay, someone asked about the normal return time of blood to the fingers when we do
10 seconds.
10 seconds.
You're doing this and you hold it for 10 seconds open, it'll be back, and 5 to 10 seconds. 10 seconds is long. You're holding it for 10 seconds. When it comes back, 5 to 8 seconds, very quick.
Okay.
It's like you doing, boom, it's there. It's not, oh, it's slow. It's if you have to think about it, it's too long.
Okay. Does someone have to appear with a nutrition deficiency to be considered to have disordered eating? Are there eating disorders on the opposite end of the spectrum from deficiency, for example, overeating, emotional eating? And do you have recommendations that are different for these cases?
Well, So let me just make sure I heard the whole question. So,
Mhm.
so you're asking if there's nutritional deficiencies for a person that struggles with emotional eating or binge eating.
This person is asking, does a nutritional deficiency have to be considered? Does there need to be a nutrition deficiency to have an eating disorder?
No, it's their relationship to food. If they eat to soothe and numb and suppress, that's an eating disorder.
Okay. And then the second part of that question was, are there eating disorders on the opposite spectrum from deficiency, like overeating or emotional eating? And what recommendation?
Well, if a person struggles with binge eating disorder, whether they eat out of boredom or anxiety or because it looks good, there could be, nutritional deficiencies. It just depends, I think, on their genetics and what they've been binging on too, and how their blood work will show up. And again, it's helping a person. So, my approach would be working with them on how to become an intuitive eater.
Mm-hmm. Okay, thank you. Can a major gut issue as an adult be a result of anorexia as a teen?
Yes.
Okay. I work with a teenager that admits to restricting their eating and has symptoms of anorexia. When her parent tries to get her to be admitted to an eating disorder program, they say her daughter's symptoms are not, quote unquote, bad enough. Would you say working with a dietitian and specialized therapist is better or worse? Hold on, I'm being blocked here for a second. Better or worse than being in an inpatient or outpatient hospitalization program?
I would have an assessment with a different program. I mean, you could be assessed with outpatient providers like me, an outpatient dietitian and therapist. But that makes me sad to hear that a treatment center saying that she's, quote unquote, not bad enough. My initial response is like, be evaluated somewhere else, because I don't know any that would say that, but you never know. And there's so many programs out there too. I mean, they're all very full and with waiting lists, but there's plenty of programs and competent people that work in these programs to assess her.
Thank you. I think we have time for one more question.
That sounds right.
This is from me. I'm curious about the onset of eating disorders through the lifespan, when it's most typically seen, and if they can come about in the geriatric population.
Yes, I actually, Rachel, just did an interview for this yesterday because I lobbied on Capitol Hill before COVID for the Eating Disorder Coalition for Eating Disorder Advocacy Day. And actually, the Affordable Cares Act, the Medicare population is the largest growing population to develop eating disorders, oftentimes due to being an empty nester or losing a spouse or a child moving away, and perhaps they were chronic dieters or had an eating disorder earlier in their life, but whatever problem evolved in their life, that was what contributed to the development of it. So yes, it's very, very common, actually.
You are doing incredible work. You really are shifting how we look at eating disorders and the language. And thank you so much for this information. It was wonderful, Robyn. It was fantastic. And again, I thought the book was so helpful, especially for learning more sensitivity with language for me as a clinician. So thank you so much, Robyn. The Scottsdale Youth and Coalition thanks you. I'm going to pass it to Jordan, who has something wonderful to say as well, I'm sure. But thank you so much. It was great.
Yes, thank you again. And I know there's a big virtual round of applause going on if you see that chat meter go up right there. So again, thank you so much. And thank you to everyone who joins these. And we're so glad you could be here.